Hello, welcome to the video. This is Dr. Prashant Talanayar Muthukrishnan. I am one of the pulmonary critical care physicians at Albert Einstein College of Medicine, Bronx, New York, in North Central Bronx Hospital and Jacobi Medical Center. I have been trying to spend some time journaling as I go through these experiences here in New York. And I would love to share these with you to see if it relates to each one of you in your own respective communities. So I'm going to use the cheat sheet right here. So I beg your pardon, since I'm trying to keep a close eye on what I'm talking about. So starting to talk about the experience in the hospital itself, the administration, and the logistics. Okay, we'll talk about that in this video, and then subsequent videos we'll talk about what should the public be doing during this time of epidemic, and what are the lessons to be learned. Okay, so from March 16th onwards, our ICU had we had 20 beds that were starting to get filled up with COVID-19 patients, and they had severe acute respiratory failure. We are trying to still figure out whether it's ARDS or is it atypical of ARDS, acute renal failure and shock. By 25th, we had all of them on ventilators, and 2 were manually proned, and which is sleeping on the tummy. We are learning to still strategize the division of scarce labor and attempting to protect ourselves to stay fit so that we can fight till the end. Our civilian patients, nurses, physicians, administrators, housekeepers, all of these are really gods in human form, for coming here and helping us. We are trying to provide, help for nurses and fellow colleagues with multiple unstable patient events happening simultaneously. And when these guys are stressed, hungry, or thirsty, then the experience is going to be really painful and compromised. So that's what we're trying to help out, besides many other aspects. So we were never trained to fight a world war. A balance to the offense and the defense. These are 2 important sections in our army, and whenever we fight a war, we need these 2 to be strong if we want to fight it till the end. Nurses, doctors, assistant staff, imagine them that they are the soldiers, and then the virus particles we think are the opponents here. The civilians that are fighting alongside with us, they are analogous to our patients. And we are balancing between being self-protective and selfless while serving for these patients, as we want to fight till the end. We are sharing real-time experiences from the ICU. I'm also quoting a little bit of teachings from various holy scriptures and analogies from the World War strategies in multiple different videos here. And this form of self-journaling is really helping me grow as an ideal human, as they explain in the Gita chapter 2. We analyze various interpretations of the epidemic from different angles: medical, industrial, professional, marital, social, familial, spiritual, political, and so on. The virus, the soldiers, the battlefield are analogized with many other different life scenarios in some of these videos. And in some, stress actually can be coined as the most powerful analogy to this virus, because that's what we as doctors right now are experiencing. And I'm sure there are a few people in the public that is also experiencing stress due to various reasons. So this video, I'll try to stick to explaining to the physicians what were the events that happened, so that you guys can also see if you can do these things in other parts of the world that are even just now getting ready for the epidemic. So number 1, in February, we started getting email communications with about national seminars, webinar conferences, papers from China, and we started alerting our own community about the emergency preparedness for the ambulatory centers and urgent cares. And then we started looking at how is the patient going to come from the ER, where is the patient going to go, the patient flow, how many negative pressure rooms do we have, and wherever there was already a discussion, it really helped in avoiding delays and uncertainties and stress. Then we got departmental communication about plans to close the unnecessary outpatient clinics that could be prevented. Those were very useful. And we're still now trying to figure out when can we restart those clinics so that we don't miss out on these patients. And they might potentially turn into emergencies later for certain semi-elective surgeries that are still waiting. Also, we started looking for extra coverage of physicians for the upcoming weeks, and how to get our non-COVID patients taken care of. And then finally, some of the inputs regarding the flu season may have delayed our response to this epidemic. But these have made us stronger, and so from March 17 onwards, we started getting our first batch of patients, and we stood up this challenge with a steady mind and intellect. Now, let me go to a different approach here. Here, what I'm going to do is talk about what are the clinical and the logistical challenges that the physicians need to know. Okay, number one, isolation precautions, contact and droplet will be the minimum. You don't really need shoe covers as long as you're wearing a shoe specific to the hospital, and then you remove your shoe and have a different pair of shoes when you head back home, and try to have an entire new set of clothing when you enter the hospital and leave the hospital. So we try to keep track of CDC and WHO data consistently to make sure that we are following them regarding precautions. And then the flow of the patients in the ER and the wards, we made sure that we let the ICU know when there's a patient in the ER that could potentially collapse. And then, how we have changed our guidelines every month is important here. Initially, we were looking for only travel history, and whereas later we changed to just community-wide spread for the virus. And we have about 20 ERs, ER beds with 10 pods, open pods with curtains, and some 20 ICU beds, 40 surgical med-surg rooms, two PACU closed rooms with other 6 to 8 pods. So, and this is where we strengthened our defense strategies for our staff by ensuring that there's adequate N95 mask as much as possible, trying to use it one per day. And if at all we needed an extra one, we knew that there was a solid reason for asking for the second one. Contact gown, goggles, caps. And these days, we are trying to be really innovative with gowns. And that's the function of a war time, right? You get what you have, and we make the best use of what we have. Some staff were inconsistent with the use of the above PPEs, for example, not very meticulous about getting covered completely when they enter, and we made sure that we catch those people and guide them through this. Ask them the reason why they are not interested in completely covering them. Trying to avoid delays. They're trying to get back into the patient room because they just missed out on something, and so on. So, specific transportation for patients from the ER to the ICU or to the radiology suite, that was very helpful. And so that is regarding logistics. Next one is scarcity of dialysis capable rooms. That'll be a major obstacle or a challenge in the upcoming days for other hospitals if you're starting to see these patients, that if you have only certain rooms in the ICU that are dialysis capable, then that may hurt your chances. I'm not talking about CVVH, but regular dialysis. And we made sure that we plan these patients, at least in the first 3 to 4 days. We put these patients in areas where there was no need for dialysis, and then moved patients towards the other side during that later phase because they needed dialysis. So that could be helpful. And these COVID patients, they took much more time and manpower compared to non-COVID patients, because we still had a few non-COVID patients left out from previous weeks. And so for those patients, for example, we tried to get them out fast by tracheostomy for 2 of the ventilated COPD pneumonia patients. And so such ideas were very helpful. And the surgeons were super helpful in getting the tracheostomy, done. There was a seizure patient, and his care was not, easy, given that there were other unstable patients, all around him. And that's where we tried to prioritize our time. Quality of care versus quantity of care is important, because we accepted patients from other hospitals just to help unload all the other parts of the city. We were trying to debate, doing that versus being able to help already existing patients in our own hospital. But then we said, the best place for a COVID patient to be in would be an ICU and not the ER. So therefore we said, let's get him here and at least keep him comfortable. If we're not able to provide the best care, at least we could give him a place in the ICU and be on good sedation and be taken care of symptomatically. Use of ultrasound machine, in diagnostics was a challenge, given that there was scarcity of time, because you need to spend time when you try to do IVC studies, trying to find fluid balance, etc. And while we were trying to take care of some of these diagnostics, some other patient would become unstable, and so therefore, it is important to prioritize these things, and be minimalistic in terms of any therapeutic measures, so that even if it's a fluid challenge, slower and small, frequent challenges were much better than large boluses at the time. Now, it's a number of times that a healthcare worker entered a patient room. We tried to be strictly vigilant on the risk-benefit ratio of the offense and the defense strategies during such patient care, monitoring the use of N95 masks, PPEs for our surgeons who used to help with some procedures. Those were important. And every aspect of this epidemic, there is this offense and defense ratio balancing that we are trying to do. And we've persevered consistently on identifying and timing our diagnostic and therapeutic procedures with the help of real-time analogies to the military and sports concepts of offense and defense. For instance, nourishing our healthcare staff with food and water on a consistent basis every few hours, so as to keep their mental faculties and efficiency of the soldiers, right, at the best levels to achieve best patient care and making a lasting experience for all of us. Portable radiology was also very critical in terms of trying to find the benefit-risk ratio of them trying to move the patient, possibly dislodging the ET tube and getting aerosol exposure. So that's something important. And trying to make group huddles early in the morning so that you know what are all the list of things that the nurse needs to do, so that the nurse only enters 1 or 2 times during a 4-hour shift. A scarcity of physician manpower for multiple events at the same time. Yes. So, that's where we improvised spontaneously with division of labor. We got the surgeons, we got the anesthesiology groups to divide and conquer this. Residents and interns were trying to understand their role in such busy times, and that's where the team steps principles really helps. Self-defense, data gathering, reporting, documenting, blood work, etc. Nurse charting, yeah, we definitely need to convey this point. It was very useful for our nursing colleagues to find out what is the most essential data that they need to keep charting, so that they don't spend a lot of time on the computer, and they can still get out on time and just actually get the most essential information for us when it is eyes and nose, for example, intake and output, and so on. So another challenge was dialysis catheters sometimes not working well due to either the obesity of patients, hypovolemic patients, clotting of blood, because some of these patients tended to have very a tendency towards clogging these catheters. So that's something that you should predict. And sometimes just repositioning the dialysis catheter is important. But again, you will get exposed to the patient because you will have to go back into the room when the dialysis technician calls. So these are things that you need to predict much ahead of time, so that the dialysis technician already knows that he needs to adjust the position, for instance. And we had limited staff for CVVH during the initial phase, and that's where we had to use SLED, slow dialysis. So that was one of the useful tips that we got from the dialysis, from the nephrology department, central lines. This is one important thing we noticed, is that from day 1 to day 4 or so of these patients, they did not need dialysis. Their acute renal failure was slowly worsening. And a few times patients came in with central lines and they had to be changed, because now he was from an outside hospital and we were concerned about sepsis. And that's when we said, why don't we put in a trialysis line, which has 2 dialysis ports, and then the third port is a central line port, so that we can use pressors if the patient becomes sick. Okay, and central lines. So when they come from outside hospitals, there's always concern for line sepsis with ongoing fevers, and patients were received from outside hospitals or ERs. And so empiric antibiotics started in many local and outside patients without endotracheal samples for finding out if there's any lung sepsis, bacterial sepsis or not. That was important. Decision making regarding empiric antibiotics. Once COVID, there is a lot of confusion between, okay, when should we stop antibiotics after the COVID results come back, and do we really need to finish a course of antibiotics or not? And those are things that'll come up. And for that, it's a good idea to make sure that your blood cultures are drawn right away on admission, as well as getting a endotracheal sample or sputum sample, so that that to begin with, that there was no bacterial sepsis at the time of starting antibiotics. So that's important. How did we address telephone? So we tried to, again, divide and conquer. We spoke to our social workers, and they were super helpful, and also along with our interns. So patient families calling in, asking regarding patient updates, we made sure that we had a balance towards the positive and negative feedback, listening to their experiences at home, trying to get the social workers, case managers, and we also had some residents working on small prospective COVID patient projects research, so that they have another chance to speak with these families and also get consents for prospective review. CPR related questions were dealt with by initially asking about the presence of advanced directives, is he already DNR or not, and then sharing the pros and cons of the entire process, and mentioning to them that the risk and the benefit ratio, given that they're so sick to begin with. So this is one of the most important things that we notice. Fear of consequences of an action did not really help during therapies for this novel disease, because we really are still trying to figure this out. So emoting a lot to the actions that we've committed or omitted. We made sure that we had a balanced approach to analyzing these things, and positive reinforcement definitely made us stronger every day, and our patients are now living. So that's some of the important things with logistics wise. I'll try to finish a little bit here on the other clinical parameters. Number one is so the need for intubation and the initiation of mechanical ventilation was also very challenging, regarding the use of high flow nasal cannula, BiPAP, CPAP, etc. And end-tidal CO2, given that there was dead space ventilation, increased dead space ventilation, there was always a gap between the end-tidal CO2 as well as the PCO2. So that's something important to note. We had a lot of edematous patients and delays in blood work due to poor access, that we try to make sure we work on these things as fast as possible in the early morning hours, so that it doesn't intervene in our decision making. Fentanyl, propofol, we are slowly running out of these medications, so we try to rotate between different sedatives also. And some of these patients, when they used fentanyl, they had constipation, and we were trying to use caxolate for renal failure, and that had some challenges. Variable response to PEEP and FiO2. So maybe we're already receiving some inputs from Italy and China saying that maybe being moderate, around 10 to 15 of PEEP may be the best strategy. Again, driving pressure is super important. When your plateau pressure goes up more than the amount of PEEP that you go up, we call it the stress index, then that's something that's very useful, because now we're thinking that this could be basically a VQ mismatch from severe coagulation that's going on in the pulmonary vessels, versus cytokine storm causing vasoconstriction. So staying detached to the outcomes of the therapies we omit and commit, not taking outcomes personal to you, so that we can receive actual factual signals from the patient response, and learning the disease is very important. Understanding the magnificence of this creation and the creator, alongside these real-time experiences, will really help us grow a lot. Engaging in action with a balanced effect, but at the same time not going towards inaction, as the chapter 2 of Gita says. So some of these potential facts to consider in the future would be antigenic shifts in, drifts of the coronavirus, just like the flu. So, do we really believe that vaccines alone will solve the problem, or is there something more than vaccine? And that's when we start looking at the gut healthy lifestyle practices, and so that, because we know that some of these patients who have survived COVID, they seem to have something inherent with them called innate immunity, and that's what we need to focus on. And let's try to duplicate such good gut immunity in our chronic disease patients. Role of nutrition support and balancing priorities versus duties is very important. Duties towards the self, duties towards self-health. Continued follow-up of our public and the healthcare workers over these next few months to make sure they mentally they're doing well. Understanding the message of this entire pandemic is like the big picture, saying, the goal of Mother Nature, what is she trying to tell us, as against medical and political aspects of the disease, and also personal behavioral responses to such epidemics. What is the public doing at their own homes? How are they reacting and acting to this, acting on this epidemic? So, we've seen an amazing outcome for this epidemic just from the telephone visits of all our non-COVID ambulatory patients, outpatients. So all elective, semi-urgent surgeries, cancer, cardiac therapies are being put on hold, and we are trying to get back to them somehow as soon as possible, so that they don't transform into emergencies, right? So these are the logistic and clinical parameters that I think will be really helpful. And there's many more, including use of anticoagulation for D-dimer being high. And then right now there's also concern about the hemoglobin that's being affected by the virus possibly. So those are some of these things. And we'll continue on a different video to talk about more personal and practical ways of looking at the epidemic. And I will meet you on the other side of this video. Thank you very much for being here with us.